So our talk today will be delivered by Dr. Laura Funk from the Department of Sociology and Criminology here at the University of Manitoba. Dr. Funk's talk is entitled, "Where Would Canadians Prefer to Die?" A mixed methods policy research study, which is based on funding from SSHRC. I know that these and a lot of related issues are prominent in the news in Canada right now, so it's great to be able to hear from an expert in this area.
Great. Okay. So with that, I'll get underway by just introducing a recognition here that this is a project that is part of, we have a very large interdisciplinary team and several students on board. So there's a list of the full team at the end of the presentation. Just move something around here. There we go. So I'm going to flip to the next slide. So these are some recent sort of reports and news coverage that came out around a CD Howe report that was released recently that talks about the importance of, that Canadians don't often die in a place that they don't, or they often die in a place that they don't want to be, and that the delivery of palliative care needs to be aligned with people's preferences. And so those were kind of phrases that for me were quite interesting, because that is a project that we're working on currently. And I think this is also, I posted here an Andre Picard piece that emphasizes Canadians aren't dying as we wish. And what's interesting is that when our team looked into it, that Canadian evidence on preferences was actually pretty sparse. There was one study in Alberta, I think in 2010, where I think they found that about 71% preferred to be at home near death compared to alternatives. And then there was a CHPCA national study in 2013. And in that one, about 40% of respondents expressed no preference. And of those that did express a preference, 75% preferred home. And then there's been some research with hospitalized patients who are closer towards end of life. So with those populations, the study that we have suggested that there was an average preference for home death of closer to around 53.6%. So it was something that we've sort of been noticing, and it's of interest to our team, because as well there is a home death is seen as a positive indicator of health system function. So this is the Canadian Institute for Health Information, and they're developing this sort of indicator around this piece in particular. So our team is quite interested in exploring public preferences among Canadians for dying in different locations, and in particular for dying at home. And we want to unpack some of the complexity and variation in terms of what that even means for people and how they understand it. So our study highlights gaps in particular in how public policies understand dying at home. And so what I'll talk about today, hopefully by the end of this, we will sort of have a sense of how some of these policy understandings and sort of dominant narratives around this can obscure what is in fact a really kind of contingent or conditional sort of phenomena, which is end of life, preferences for where you would like to die, and also that this is very relational as well. And that these narratives around dying at home can also obscure what tends to be a kind of cost shifting or a burden shifting often to families caring for people towards the end of life, and really contribute to one of the implications of this is that families who cannot help someone die at home can feel particularly guilty. We do see our team has noticed even prior to this study that there's some tendency towards an idealization of dying at home in terms of kind of the understanding of what might be involved. And also through this study, we've really looked at how dominant policy narratives can obscure inequities shaping experiences of dying at home, and whether or not we even have a choice, which is also really important to consider. So this some of the research questions for our study, there were two sort of focused more around policy. So looking at how dying at home is presented in Canadian policy documents, but also what is the role of public opinion in how policy in this area is developed. to what extent is evidence around preferences integrated, and how is that evidence understood? We're also quite interested in, probably the main focus here is around what are Canadian public preferences around location of dying, and also who do people view as kind of responsible for providing the care towards the end of life. Another piece of this is, again, as I mentioned, that sort of unpacking some of the complexity around the meaning. What is the meaning of dying at home among we looked at stakeholders and advocates. And so this was mixed methods in the sense that we have looked at a number of different forms of data. We're still at the stage of sort of integrating the findings from these various sources, which is really more about the comparison between sort of, or the juxtaposition between the policy and the sort of public, in-depth public understandings of this phenomena. So we've done a discourse analysis, a national panel survey to measure public preferences. And in fact, we were able to replicate this because the original one was done prior to the pandemic. We've done another one post-pandemic, or sorry, during pandemic as well. And then we had some qualitative data with policy and organizational sort of government representatives, as well as a diverse group of other stakeholders that I'll talk about as well. So the analysis of policy documents, Erin Scott is a student at the University of Manitoba, and she's leading this particular piece. This was looking at sort of it could be publicly available statements, reports, or websites of provincial and federal governments across Canada. We're really interested in any of those kinds of statements around location of dying and dying at home in particular. So it could be an end-of-life palliative care documents, as well as home care. And of course, there's limitations here on what is publicly accessible, and we have to remember that policy refraction occurs as formal policies are implemented in practice within health authorities, but it gives us an overall sense of sort of the scan of kind of what is said about this publicly within the policy arena that is hopefully sort of seen as kind of aspirational as to what we might be working towards. So Erin Scott's analysis has identified within these documents the presentation of the location of where people die as sort of an uncomplicated choice between options. So really kind of there's this initial sort of very neutral framing of this as a choice for everyone. And then there's also, though, alongside of that, a more subtle but fairly consistent or persistent emphasis on home as the ideal and preferred place for both end-of-life care and for dying. And this is sometimes framed as something that's beneficial for the individual, but also for the system in terms of healthcare costs in particular. The fact that people want to die at home is frequently mentioned and sort of naturalized as common sense. So sometimes there weren't even references for those kinds of claims. And there's, again, no sort of recognition of how the preferences that people have can change over time or with conditions. And then this is probably not surprising, but then the costs of, or the capacities of families to be able to help someone die at home is really not mentioned. So we say that's obscured within the documents. Also, within palliative care philosophy, the families are actually supposed to be part of that unit of care, and also receiving bereavement supports and so forth, and having the support of palliative care teams, and that piece is also obscured. The gendered aspects of care also not mentioned as well. And also the sort of access to services that would make home death both desirable or attainable for people is also often obscured or not present, except within rural and remote communities. So that issue was raised, and then sometimes for people with specific sort of medical conditions towards the end of life. So that was the analysis of policy documents, just sort of the main themes there. And we did also conduct 17 policy interviews, and these would be current or former health executives, directors, policy analysts, a few sort of practitioners that were really sort of in the know about how policy developed in this area, some researchers as well. And it really helped us get a sense of the really complex policy landscape in this area. Um, and in fact, we've noticed as a team that palliative care and dying at home is a good example of the complexity of policy landscapes in general. So it's not unique to this, but it's really quite evident when it comes to dying at home. In terms of the things that the policy interview participants were telling us, um, they fully acknowledge the sort of funding constraints at play, the jurisdictional issues in terms of provinces and federal governments, and in this sector, a sort of over-reliance on the nonprofit sector to provide services, and that this can contribute to inequities in people's ability to die at home. Palliative home care is not widely available, and it's fully recognized among these participants that you have to have family caregivers and or the ability to pay privately for additional services if you want to die at home, especially in some areas and situations. Provincial policies in sort of health and home care are implemented and sometimes adjusted regionally, but also regions try to shape policy at that provincial level with varying degrees of success. Policy makers also told us that there was inconsistent engagement, whether over time or between regions, in terms of involving the public and involving advocacy groups. And sometimes there were contradictory statements, even where, a government official would say, yes, we really involve these various organizations and groups, but then you talk to someone from the group and they're like, no, we don't really feel like we have much of a voice or influence on the policy. We're particularly interested in what role public preferences play in policy in this field. And most of the participants in the policy folk believed that strong public demand and or advocacy was an important driver. But this was maybe more so around who are the loudest voices or who's making a fuss, rather than kind of rigorous evidence about preferences, for instance, among the public. I think one of the participants said, no, politicians know not to displease the population, so that sort of idea. So there was a general belief that, yes, most people want to die at home, and that policy generally reflects this, at least in the rhetoric, if not in the funding or the implementation pieces. But at the same time, they also said, public preferences themselves are often uninformed. If you just ask someone point blank, where would you like to die? Are they really considering, service limitations or caregiver capacities and so forth? And they also spoke about sort of the role of government leadership or the state of the relationship between the health authorities and the ministry, funding, obviously, politics, and then sort of administrative and policy capacity within governments as barriers to policy development in the area. And the policymakers did acknowledge that some people do not wish to die at home, and that they also may not even have a choice. And some emphasized the need for indicators really that capture more around the quality of care or the quality of death, rather than proportion of home deaths, which tends to be the sort of dominant indicators. And as much as we hear sometimes about home death saving systems money, there's also investments needed in order to increase the proportions of home deaths. And the other key point here is that the participants also felt that policy tended to ignore issues related to family capacity or burden and supports for families as well. Okay, the place I'll take you next is to just give you a preview of 3 vignettes that we used in the surveys to assess people's preferences for location of dying in a very contextualized way. First example here, asked people to imagine that you're currently dying from an illness, and in addition you have only a few symptoms associated with that disease. You'd rate the severity of those symptoms as 1 out of 10 and have no difficulty coping. The other things to note here are that we have also set up a situation here where the family and friends are always available, and healthcare professionals and services are also quite present. So this is what we'd call sort of our mild scenario or mild severity scenario. And then we said to people, in this situation, how much would you want to spend your last 2 weeks of life in the following places? Where 1 is not at all and 5 is very much. So then we had a big list of your own home, or the home of a family member or friend, and then acute or intensive care, hospice, palliative care, a nursing home, or another place. So with that, so that was our sort of mild situation. And then we had a situation that we characterized more as sort of moderate, where you had several symptoms associated with the disease, some difficulty coping, family and friends are usually but not always available, and healthcare professionals are not necessarily always available readily as well. And that's the same question. And then we had the sort of severe scenario or situation in which you have many symptoms that are quite severe. You have a lot of difficulty coping, no family or friends available, and healthcare professionals not available. So those are the 3 vignettes that I'll refer to subsequently. And this is I'm going to just walk you through the pre-COVID version of the findings that were offered to folks in French or English through Qualtrics, and so it's called a panel survey. So it's not, the caveat here is that it's not completely random, but allowed us to quickly generate a sample of 2,500 general population adult respondents in Canada. And thanks, I think Chris Campbell is on the Zoom call here, and thank you to him for helping us set some of this up. We used some quotas here in terms of making sure we had enough representation from certain age groups, from those who spoke French, and rural residents. And then for those interested in the statistics here, we're looking at ANOVAs that we conducted between people's sort of stated preferences for, we're going to look at 4 sort of places of death, and then looking at how that varied by the vignette situation, whether that was the mild, moderate, or severe. And the ones that I'll present here are one that's sort of mapping this based on another question in the survey, which was around, actually it was a measure of family, sort of support for family obligation. So that was a scale, and then we grouped that into high and low. And then we also looked at 3 age groups to unpack this a bit further. So I can walk us through the key findings here. All right, and I've got a table in a minute. So basically, as the severity of that scenario increased, the respondents' preferences for dying at home decreased, and preferences for dying in palliative care, long-term care, or even in an ICU increased, sort of proportionately. We also found that for respondents with high family obligation scores, or attitudinal support for that, home dying actually did remain the preferred option over time, even in that most severe vignette. Whereas for respondents who were sort of ranked on kind of maybe low support for the idea of family obligation for care, both ICU and especially hospice or palliative care unit were preferred in that most severe vignette. And for older adults, preferences for palliative care or hospice approached those similar to that of home in the moderate vignette, and by far surpassed it in the severe vignette. We also found it interesting that those oldest respondents even seemed to prefer dying in ICUs over home in that severe vignette situation. So the first set of tables here are high versus low family obligation. This is sorry, the legend might not come through here well, but essentially the stripy column is home, the next is ICU, the next is palliative, and then the last is long-term care. And this is the difference again between the high family obligation. For instance, you can see that home remains sort of slightly dominant in the last severe, but still quite high. with palliative care increasing up a bit over here. And then this is the low family obligation score where palliative and hospice care increases proportionately here. All right, and there is the same sort of example. We're breaking it down here for ease of presentation, between the youngest group and the oldest group of respondents. And again, home here for younger adults, still slightly preferred even in a severe situation, and then fairly low for the older adult group here. But also interesting that ICU is even so high even in that situation. And we can talk about this further in the discussion and comments. What I want to move now to, though, is the last piece of the study around unpacking, like, what is the sort of complexity of the meanings around dying in different locations, and dying at home in particular. So shifting our focus from preferences per se to complex meanings and conditions around dying at home. And so we initially planned some focus groups, but COVID sort of derailed that at the time, and we shifted to sort of Zoom qualitative interviews with a range of types of stakeholders, advocates, or representatives of groups. Ideally, we would have wanted to get marginalized groups included, as many as possible, and in some cases what we had to do was sort of interview, say, service providers who worked with, say, structurally vulnerable populations, which is what we did as well. We also talked to quite a number of compassionate care community advocates. So those folks generally tend to be more supportive of home death, and working within kind of a mutual aid sort of approach. We did also want to speak to palliative care professionals themselves as to what their understandings were of this. I'm not going to classify participants into certain groups here, because many of them also had more membership in more than one of these categories. And in fact, a few, although it wasn't part of our recruitment strategy, a few also identified as Indigenous participants as well. So I'm not going to break down the numbers here, but just give you a sense of the types of groups we looked at. And I'll present three key themes from those findings. And the first is just sort of exemplified in this quote, that anybody would rather be at home than in a hospital. And this sort of is this idea that dying at home and the meaning of it tends to be defined against dying in other places where, for instance, the care provided there would be undignified or unwelcoming. For some participants, even hostile. So the LGBTQ participant, I remember calling at least a few of them, mentioned, really not being welcomed and sometimes feeling threatened in those settings. And sometimes these, settings also being associated with neglect and social isolation. Obviously during COVID, I mean, these interviews were conducted during the pandemic, and then although people didn't focus exclusively on the COVID context, they did sort of add these points that, even now, you're especially socially isolated within those settings. We also saw sort of the emphasis or these ideas around hospital and institutions being cold, curative focused, perhaps on something about them, the care provided there is being more unnatural. And again, especially so those sorts of comments among the compassionate care community advocates. There were some, and probably not surprisingly, the palliative care professionals, many of them talked about, well, I witnessed a good death in an institutional setting. So in fact, for me, I might say I prefer to die at home, but for me that encompasses the idea of dying in a long-term care facility, because that's where my mother died, and it was a good death. Or I'm in a rural community and that's, really well integrated there. Or I've seen people die in hospice, and they make efforts to try to make that less institutional feeling. So those sorts of comments also were raised as well. And this idea that something came out here too around the idea of home as the meaning of home as feeling connected and integrated within the neighborhood, and that was what was important, or feeling integrated into the community and the family, but not necessarily that the family would be providing care, as I'll talk about, but this idea that there's something about home that sort of signifies this embeddedness. That juxtaposed a bit awkwardly, though, or uncomfortably, against some of the advocates for structurally vulnerable populations who said, for them, home is none of this, right? And so, we do tend to sort of idealize this idea of home. The idea that home is a history of who I am was often seen as sort of a reason why one would want to die at home. And so the interpretations of the meaning of what home is, though, for any particular participants often reflected and reinforced their sense of identity as well. And so that, some people's identities were more actually rooted to a physical space or region than for others. I'm thinking of, one participant who mentioned, I think a younger adult who mentioned she had moved around a lot and was a renter. And so that, there's not really a specific tie to a physical place. Or if there was, it was maybe, I want to return home to my parents' house, to be closer to them, that sort of idea. Dying at home was often seen as preserving a sense of selfhood towards the end of life, especially in the context in which dying itself is not familiar. We're not often exposed to dying in our sort of everyday experiences and lives. And also it tends to be scary, and so that sort of wanting to feel that sense of familiarity around you is sort of comforting, having the things you like around you, and so forth. And again, this is maybe more when we talk about structurally vulnerable populations who might, who are sort of precariously housed and so forth. Again, that necessarily we don't have. Home doesn't have that same sort of meaning. Okay, I'm going to go to the last point here, which is one of the things we did notice was that that idea of having a broad and very symbolic definition of home, which was common for many of the participants. It may also be, in fact, kind of an adjustment of ideals given their awareness of constraints on people's choice over place of death. So as one former caregiver stated, I know many situations where people think they want to die at home and then they realize how complicated it is and it's not as beautiful and ideal as they've been told. So ultimately, we have to find the sense of home like in our hearts. So the real home is what we create around us, the sort of sense of home around us. But when speaking about either their own preferences for location of death or those of community members that they worked with or advocated for, participants emphasized aspects of complexity, variation, flexibility, nuance, contingency on circumstances. Even if this was the case even among participants who might have idealized dying at home elsewhere in the interview, but especially we saw this sort of openness to flexibility around in palliative care professionals themselves, who were drawing on their sort of a wide range of observation of different kinds of deaths in both institutional and non-institutional settings. So this phenomenon that we noticed sort of reflects the participants' own contextual awareness of the uncertainties of circumstances, whether you're dying of dementia or some sort of, what are the symptoms that you're experiencing towards the end of life. There was a lot of emphasis on awareness of the potential impact on family, and I think it was one participant that said, if you're thinking about other people, maybe you wouldn't want to die at home because of the impact on them. So this is a wide variety of impacts that they talked about, whether that's the care required of family, and the sort of emotional or kind of care burdens involved. But it could even be things like witnessing the death. If you lived with young children, where there was concerns about the impact on them in the sort of bereavement and long term, for instance. So that was actually quite a sort of major emphasis. And then just the sort of recognition of limitations to formal services that would be available. And for many of the participants we interviewed, they did have, they could speak about things like, well, I would want to die at home because I know I could afford, I have someone that can help me, and I can afford to hire privately. But we also recognize that, in some areas, and especially for some people, there's a lot of barriers to accessing formal services. And so one participant who worked with structurally vulnerable populations said that, the assumptions are that you have control and autonomy and self-determination, that you own your own home, that you can do what you want, you have your family there and your friends, and that it's your choice. And so that's just not the reality for so many people. All right, I'm going to wrap up to some conclusions. We're still analyzing the COVID survey, by the way, or the during COVID survey, where we're kind of taking the same questions and vignettes that we used before, and then there's a few additional questions out of there. But I can say that what we're finding so far with that analysis is that it replicates the sorts of patterns that we had already identified, except that I think the main exception is that the preference for nursing homes, it wasn't really that high to begin with, but it's gone down even farther. And that's perhaps not surprising because of what's happened in those settings during the pandemic, and sort of people's perceptions of those settings and the care that can be provided in those settings is fast eroding. There's been some other talk recently about whether COVID actually might be affecting this sort of what we'd seen as kind of an idealization of dying at home. We are seeing this, it's fueling more fear and of an aversion to hospitals and long-term care facilities, especially if visitors weren't able to even be there for a while. Richards and Rowley in the UK, though, proposed this idea that maybe COVID is actually shifting the narrative in the media. They were talking about that dying at home is now sort of that unfavorable outcome because people are dying at home with fewer family and friends around them even there, and fewer services. It's much less an issue of choice in the COVID context, and more driven by fear about dying in a care home or hospital and contracting COVID and so forth. So that was an interesting idea that they raised. But in terms of our overall conclusions, I think generally they would suggest a need to develop supports that are responsive to changing contexts at the end of life, and that the idea of advanced care planning in a clinical setting, talking about location of death preferences, really needs to be seen as something ongoing and over time, rather than something you just sort of document at one point in time. I think the team has felt that there's a need to nuance how dying at home and preferences for dying at home are presented in the both the policy and public arenas based on our findings. And that this probably also speaks to the need to, that healthcare quality indicator around just deaths at home may be a bit sort of overly simplistic. There's, I think, and we haven't really seen this in well, certainly policy, and it didn't come up as much even in our interviews, but we know that there are gendered realities to unpaid care in terms of who's providing the care for people at end of life, and in terms of impacts and so forth, that really also need to be addressed within policies. It's probably not surprising that we would also recommend a need to continue investments in both institutional and home-based palliative care services. And really, if dying in an institutional setting is that awful, are there ways to continue to try to integrate more humanistic and relational approaches within those settings? And then our piece around the structural barriers that we're examining is also leading us to realize it's not just about, just addressing the structural barriers at the point of end of life, but that it's about people's whole life context and history and so forth, and the need for looking at this with kind of a life course perspective, really, in order to better address those structural barriers faced at the end of life. If that makes sense. So they're long rooted and much broader than that. Okay, and there is our full team. and some acknowledgements. And then there is a website there with, I think we have a few brief reports and summaries of the findings there. But I am excited to hear your questions and comments.
Okay, well, thanks so much. Thanks so much, Laura.